We thanks Dr. Professor Mikulski for this nice illustration. Before we move to the second speaker, we just a reminder, if you have any question, you can send SMS on the phone appear on the screen, and there will be a live panel discussion after the three lectures. Second speaker is Professor Angela Cheung. She is a senior scientist, Toronto General Hospital Research Institute, Department of Medicine, University of Toronto. She will talk about bone strength assessment, DXA, and beyond that.
Everyone, greetings from Toronto. I just want to thank the organizers for inviting me to talk this morning on bone strength assessment, looking at DXA scans and beyond. Here are my disclosures. So what I would like to do in the next 30 minutes is to take a look at our current understanding of bone strength, what tools we can use to measure bone strength, and also the gaps and future direction in this area. So bone is a complex organ. It has both sort of from the cellular perspective all the way to the whole bone. If we start looking at the right lower hand corner, the whole bone, and you zoom in to look at the tissue and the lamellae, and you can see that there's a microstructure of the bone. Plus there's matrix and also cells, living cells in the bone. This is a very nice picture of osteocytes. And you can see osteocytes have a network for communication, and they are involved in telling the osteoblasts and osteoclasts and actually modulating that balance between the two. You can see all these little cells here that with all the connections, it's fascinating in terms of how complex bone is. And in 2023, bone, especially when we think of a fracture, is like a collapse of a bridge. It basically is the structure failed. So we view it from the mechanical engineering perspective. So we think about bone strength, and there are really two components to bone strength. We look at the structural properties and also the material properties. And both the structural and material properties are modulated by bone turnover. The structural properties include the size and shape of the bone, the microarchitecture, the micro cracks accumulation inside the bone, because as we do things every day, we're creating tiny little cracks. And then our osteoclasts, the cells will come and dig up and actually fill with the osteoblasts will come in and fill it. It's kind of like road work. When we think about material properties, we're talking about minerals, we're talking about proteins, and also cells. So in the lab, if you want to know what the strength of the bone is in a little mouse, we will take the bone and try to break it and measure the strength that's needed to break the bone. But obviously in the human, you can't really do that. So, when we think about biomechanical properties of bone, we're really talking about stress and strain. So, yes, bone is a structure. It has certain elastic properties. And so we think about sort of the deformation of the bone, depending on how much load we give the bone. And at one point, the yield point, the bone will deform. And at the ultimate strength point, it will break. And so different bones have different biomechanical properties, but this is the way that we like to look at in terms of bone strength. So you're very familiar with this. This is a DXA scanner. And a patient is on the scanner doing a bone density test. So that's the current way of the clinical gold standard of getting a sense of how strong your bones are. And we know that the lower the bone density, the weaker the bone. However, if you actually look at what it accounts for in this diagram that I've made up, the bone density, the aerial bone density, done by a DXA, because it's two-dimensional, we call it aerial. It's only good for looking at the size of the bone and also the minerals. And between those two factors, it accounts for 40 to 60% of bone strength. But however, when we add in microarchitecture, it can increase it to about 80 to 90%. And so over the last, I would say, 10 years or so, many groups have been looking at architecture or microarchitecture of the bone. So trabecular bone score, or TBS, is one poor man's way of looking at it. So on the left, you can see that there is bone mineral density, say 0.972 grams per centimeter square. And below that is another bone density that's fairly similar, 0.969 grams per centimeter square. But if you actually have a section of the bone, it looks very different. So the top one looks pretty good in terms of bone structure. The bottom one looks not great. And so what happened is that we can use the trabecular bone score to get a score so that we know whether it's more like the top kind of bone or more like the bottom type of bone. So let me try to explain this. So if you're looking at a forest and you are going to be asked to identify each single tree, that's not possible. However, if you're asked to identify all the clearings, is much easier. And so similarly, for trabecular bone score, we are really just trying to see how homogeneous, which is more on the right, on the left, or heterogeneous, which is more on the right, the bone is. And you can tell that by just the projection on a bone density scan. And so the trabecular bone score, as named as A, is much higher than the trabecular bone score named as B. And so by using these scores, we can actually adjust fracture risk. And so one other thing with this is that it's a unitless score. Trabecular bone score is a unitless score. So let me give you an example using fracs. First, you need to pick the right place. So I picked Saudi Arabia here. And I'm giving an example of a 65-year-old woman who weighs about 65 kilos and 160 centimeters in height, with a T-score at the femoral neck of negative 2.8. So this person actually has osteoporosis. If you look at this, like their major osteoporotic fracture risk is 7.3, not too bad, and the hip fracture risk is 2.6, also not too bad. Now, this is in a person who does not have any risk factors. But we can refine this by using the little button below that says Adjust with TBS. And so when you click that button, you can actually come to a page like this, and you can click on Yes, please compute the fracture risk adjusted for TBS. And so this is an additional adjustment for 10-year fracture risk. So when you do that, I want to show you two examples. A good TBS score, like 1.450. By the way, you have to pick the DXA manufacturer as well. So if I put in 1.450, then you get a major osteoporotic fracture risk of 6.1% and hip fracture risk of 1.7. But I want you to see how different it can be when you actually use a low TBS score, say 0.950 as a TBS score. The major osteoporotic fracture risk increases almost doubled to 13%, and hip fracture risk increases to 5.6%, which in some countries, if you have a hip fracture risk of more than 3%, there are guidelines to go ahead and treat. So this is a very important part for looking at bone strength in a clinical setting. This is IOF, International Osteoporosis Foundation, and they have also put out basically saying they put out a notice, news story saying that trabecular bone score is a validated standalone predictor of fracture risk. And this is looking at a number of studies, and it adds to aerial bone mineral density. And that's why, if you can, we're advising that people to use both a aerial bone mineral density score plus a trabecular bone score. And in fact, on the DXA scanner, there are other things that you can do to get a sense of bone strength. So bone geometry, using a two-dimensional hip structural analysis, is another way to do it. Because you can see the mineral profiles, you can extract the mineral profiles from the DXA images using the HSA software, and it's used to estimate geometric properties. Also, it actually can give you sort of the size and width and those sorts of parameters on your bone as well. But it does require some assumptions about bone shape and also distribution of cortical and trabecular bone at each site. So when you do these, what you get is maps of the mineral density maps, and this is in different areas such as the narrow neck in the aqua color, the intertrochanteric area in the yellow, and also in the shaft, which is in the gray. So you can sort of measure sort of the diameter of the femoral shaft. You can measure the cortical thickness as well. This is another, so these kinds of measurements using the software, it's available with hologic densitometers as well as GE lunar densitometers. And you can further calculate cross-sectional area, cross-sectional moment of inertia, section modulus, buckling ratio, and hip axis length, and also neck shaft angle, and get the diameter of the bone as well. So these are, some of these measurements are really biomechanical measurements, and so it can estimate these variables that can contribute to bone strength. Furthermore, on the DXA scanner, you can actually also do vertebral fracture assessment. And on the left is a densitometer sort of obtained image of the spine. And a year later, when we do the same thing, we can see that there is a fracture. On the right is a fracture at the T12 level. And as we know that 2/3 of fractures are silent, only 1/3 is clinically apparent. So doing these kinds of scans in high-risk patients is important and useful for identifying silent vertebral fractures. And once you have had a fracture, your risk of having another one increases exponentially. This is another method to look at fractures. So this is using it's called single energy femur, looking for incomplete atypical femur fractures. And so on the left, there's an image that's been magnified. You can see that there is periosteal reaction, there is endosteal reaction, with the dreaded black line. So this is what people call beaking in a person with an incomplete atypical femur fracture. But sometimes it's not that clear that they have a fracture. What you can see is that there is a regional cortical thickening, as in on the right diagram. And you can't really see a line, but you can see periosteal reaction and endosteal reaction. And you can see sort of a bump in that area. And that is, an image like this is considered to be in the spectrum of abnormalities for atypical femur fractures. Now, this is my favorite. This is the high-resolution imaging. We use high-resolution peripheral quantitative CT scans. These two people, they're both in their 60s, around 65, and they both have the same aerial bone mineral density. On the left is someone with good bone structure. You can see how thick their cortex is. On the right is someone with not so good bone structure, with lots of holes in the trabecula and very thin cortex. And if you look carefully, you can see that there's cortical porosity as well. There are holes in the cortex. And so by doing these scans, we can also get a better sense of how good the bone is. So how do we do this? Well, there is a scanner, the ScanCo scanner, where we can obtain images at the distal radius or the distal femur, distal tibia, and get a cross-sectional sort of stack of 9 millimeters. Then we can actually use the program to extract the trabecular part and also the cortical bone part. And we can calculate various things from these images. You can even use virtual compression, or what we call finite element analysis. This is the way that we test airplanes to know, is it strong enough to withstand the wind and the snow and the rain, or is it, are there weak spots? And so when we actually load the bone, like we are walking, we apply a virtual force to this. And you can then see in diagram C that there are different colored areas. The red are the high pressure area. The blue are areas where there's no bone, and of course there's no pressure. And so when we actually apply this, it looks something like this. It's called virtual axial compression. And you can see the same two bones that I showed you before. On the left looks pretty good. What you really want is all the greens and yellows and not too much red and not too much blue either. But on the right, you can see the stress area that if there's stress on the bone, that's where it's going to break, is the red part. And that there's a lot of hollow area, the blue area, where there's no pressure because there's no bone. We can also cut it in half and look at it this way. This is all done virtually. We're not cutting any bone in half per se, but you can see that the blue part is the no pressure part, the red part is really the high pressure part. And so you can see how your bone is expected to behave if there's a fall or if you're just ambulating and see the pressures of that. So what I'm going to show you now is actually data from the CAMUS data, the Canadian Multi-Center Osteoporosis Study. On the left is males of different ages, 24, 48, 73, and on the right is female in similar age. And we're using characteristic kind of average kind of scans to show you. So you can see that, let's start from the right-hand side first. You can see that as people age, there is a thinning of the cortex and the structure of the trabeculae get worse. there are more holes in the trabeculi. This happens more with women than men, but you can see that even for men on the left, there's also some thinning, not as much as women, and also some, less trabeculi, less connectivity within the trabecular network as well. So these are sort of what we found in the Canadian multi-center osteoporosis study. So now I've talked about sort of size and shape and microarchitecture and minerals. There's still things that we can't really get from this. For example, bone turnover, microcracks accumulation, proteins, and cells. So let's take a look at sort of bone turnover first. We can get bone turnover with bone turnover markers. We have formation markers on the left and resorption markers on the right. For formation markers, P1NP, BSAP, osteocalcin are common ones that we use. On the right is resorption markers, CTX, NTX, and peridinoline cross lengths. Personally, I like P1NP as a formation marker and CTX as a resorption marker. CTX is C-tylopeptide of type 1 collagen. I sometimes will use BSAP, bone-specific alkaline phosphatase, and osteocalcin as well. And what we do know is that the serum markers are much better than more stable than the urine markers. And some of the markers, you really need to fast because there's a circadian rhythm and it's also affected by food. And so most often when I do bone turnover markers, I do them fasting in the morning. The other thing is bone biopsy. So bone biopsy serves a very important part in looking at bone strength as well. Nowadays, we're doing through and through, meaning we get both sides of the cortex type of biopsy through sort of an anterior approach rather than when we do bone marrow from the posterior iliac crest. This is a through and through from an anterior approach. And you can see that you can see both sides of the cortex and the trabecular. You can see how well the cells are or not, which can give you an idea of bone turnover as well and the health of the cells. So you can also see whether the bone is mineralized or not. And so this adds to information for bone strength. So what I've done over the last 20-30 minutes or so is to go over the current understanding of bone strength. And so we are currently taking a very biomechanical approach to bone strength, and that we know that aerial bone mineral density only plays a part, and that there are other measures, especially trabecular bone score, that can contribute to our understanding of bone strength and our fracture risk. And there are many tools right now other than your bone densitometer for the two-dimensional DXA scans. Most of them are in research settings, like the HRPQ-CT or even QCT, quantitative CT scan. And I think as we go forward, we would be doing more research in trying to have a better handle on bone strength and how we can measure it in the clinical setting. With that, I would like to thank all of you and happy to answer any questions.